So it's my pleasure to welcome Dr. Musa Alzahrani, who's a consultant in hematology and BMT and assistant professor at King Saud University. Dr. Musa will talk to us about the role of assessing response to CAR-T therapy using PET scan in large cell lymphoma. Please, you can begin, Dr. Musa.
Thank you very much again, Dr. Musab. Okay, so I'm going to be presenting this study, which is a retrospective study from a UK group on early PET response in patients with CAR-T, diffuse large B-cell lymphoma patients. So as we know, about 80% of patients with relapsed refractory large B-cell lymphoma respond to CAR-T therapy, but only half of the responders have long-term remissions. It is unclear how to discriminate between the transient versus long-term responders after CAR-T, and at which point of insufficient response further therapy should be considered. And we know that PET scan is a very powerful tool to assess the depth of response in lymphoma patients and potentially guide the therapy in diffuse large B-cell lymphoma. So the aim and the methods of this study was to assess the PET scan based on a 5-score DEVIL score at 1 month post-CAR-T as a predictor of outcome. So this was a retrospective analysis of patients with relapsed refractory diffuse large B-cell lymphoma treated between February 2019 and December 2020 with the licensed products of CAR-T across 2 UK centers, and who were available for response at 1 month and 3 months after follow-up. So this is the standard basically response criteria that was published by Chisson in JCO in 2014. As we know, so based on the DEVIL score, we have complete remission defined at the DEVIL score 1, 2, 3. And then partial response defined as DEVIL score 4 or 5. And 4 is moderately increased above the liver, and 5 is markedly increased uptake compared to the liver, but decreased from the baseline. For any new FDG avid lesions, it will be called progressive disease. For stable disease, it is DEVIL score 4 or 5, stable from baseline with no new lesions. So the patients were included in the study were 90 patients with 2 products. So the Axi-cell, the KITE product, Yescarta, 79 patients. So the majority of patients were Axi-cell, and Tisa-cell, the Novartis product, were 21 patients. So the median age was 57 years old. The ECOG performance status prior to the infusion was 0 to 1 in 13. 57 of patients, or 63%, were male. The majority were de novo diffuse large B-cell lymphoma, so 61% of patients. However, they also included transformed lymphoma, 32%, and the primary mediastinal B-cell lymphoma, in 7%. Stage 3, 4 patients were 71%. So the majority were advanced stage. They also included double head, triple head lymphoma, as well as basically the dual expressor, 21%. The cell of origin were GCB type in the majority of patients. And about a third of patients had elevated LDH and bulky disease. And extranodal involvement, more than 2 sites were present in 57%. Again, showing basically high risk kind of patients in diffuse large B-cell lymphoma. And with this, so there were 2 PET scan, as mentioned before, done. One done at 1 month period and another one at 3 months period. So we can see that CR was found in 31 patients, and majority had the DEVIL score of 1 to 2, and 13 of them had the DEVIL score of 3. So out of the DEVOL score 1 to 18 patients, at 3 months, the majority remained in CR, so 78% of them. However, 22% of them had progressive disease. Out of those who were DEVOL score 3 at 1 month, 54% remained in CR and 46% progressed at 3 months. This is in comparison to the PR group, so 35 patients in this group. The DEVOL score was 4 or 5, as mentioned before. So in the 27 patients with DEVOL score of 4 at 1 month, so 33% of them remained in CR, and 33% of them progressed, and 33% of them remained in PR. The patient who had either stable disease, 2 patients, or progressive disease, 22 patients, all of them had progressive disease at 3 months. So looking at progression-free survival according to DEVOL score, we can see a very clear difference between DEVOL score 1, 2, as compared to higher DEVOL scores. And you can see the p-value is very significant. And you can see the very poor prognosis of patients who have DEVOL score of 5 as expected. So this is the overall survival, again, according to the DEVOL score. And you can see that the p-value is borderline. So there is a trend of showing worse overall survival in patients who had DEVOL score of 5. But it seems like the lines between DEVOL score 1, 2 and DEVOL score 3, 4 are overlapping. Probably there is no significant difference, a statistical difference between these 2 groups. So in the multivariate analysis of progression-free survival, they included DEVOL score 1, 2 versus 3, 4 versus 5. They included ECOG performance status 0, 1 versus 2, high LDH or normal LDH stage, limited stage versus advanced stage, extranodal involvement, yes or no, and bulky disease, yes or no. And in this multivariate analysis, the only variable that was significant was the differences in the DEVOL score between 1, 2, and the higher scores. And you can see the p-value was significant. All the other p-values were not significant. So in conclusion, early PET scan response using a DEVOL score criteria may be useful to predict the risk of relapse post-CAR-T therapy. And patients achieving a DEVOL score 1 or 2 by 1 month show excellent long-term outcomes. Patients with DEVOL score 3 or 4 might benefit from additional combination therapies or approaches, and they might be considered for clinical trials. And we saw clearly that DEVOL score 5 at 1 month, these patients have very poor prognosis, and they should be regarded as treatment failure of CAR-T. This is the acknowledgements of the investigators, and the study was conducted in King's College Hospital and Newcastle in London. Thank you very much.
Thank you, Dr. Musa. Very nice abstract. Can we please open the question box to check if we have anything from the audience? Okay. So one question that I have on my own, obviously the most important factor or implication, I guess, of using early PET scan is to try to predict how these patients are going to do. And there's already some thought about consolidating some of those patients with an allogeneic transplant, especially given the high failure rate of CAR-T. So as you know, about half, and in some series, probably more than half of patients will relapse after CAR-T. So the question that I wonder is that in these patients that have a DEVOL of 3 and above, is it worthwhile, for example, to see the persistence of the CAR-Ts, to see if they may benefit from a second CAR-T infusion, and I guess if they don't, maybe take them for allogeneic transplant upfront because the failure rate is going to be much higher?
Very good question. I think we need more data to replicate the study finding, since this is a small retrospective study, but I think there is a clear signal from DEVIL score 5, at least, that these patients are failing. And I agree they should be considered for additional therapy. For DEVIL score 3 or 4, other strategies, as you mentioned, considering either additional therapies or autologous transplant or consolidation with other methods, I think it should be strongly considered in these patients.
Thank you, Dr. Musa.
You're welcome.